Our pre-conference session, this is our pre-conference session on building applied skills in dementia care. So over the years, we've had our big main conference usually on Fridays, and then this pre-conference session ahead of time. And again, what we really hope to achieve is to help all of us become more solid clinicians and feel like we have a good footing on some of the basics for care quality in dementia care for our patients and families. I'm Cindy Carlson. I'm director of the Wisconsin Alzheimer's Institute. I'm a geriatrician here at University of Wisconsin, and also help lead the dementia clinic at our Veterans Affairs Hospital here in Madison. So I am thrilled today to be able to join with you in learning from our speakers. Again, this is so exciting that WAI has been involved in education for the last 20 years in this area. And so you'll see that theme carried through today and tomorrow. So again, even with our brochure that we have highlighted here, Jody Craner, who was able to find the cover for our, one of our earliest Alzheimer's disease update brochures. So you can see here that there's been a commitment to improving intergenerational care of persons with dementia and also to equity and diversity throughout WAI's history. So we're really building on the shoulders of colleagues, Mark Sager, Bruce Herman, Barb Lawrence, and numerous other colleagues, Suzanne Bottom-Jones and others who have, and all of you who have committed to serving persons throughout the state who are struggling with this journey. So thank you all for being here and for being committed to learning together. We're really excited about our presenters today. Again, these are wonderful colleagues from University of Wisconsin, Medical College of Wisconsin, and our VA hospital here. So we really look forward to great presentations today. Now I have to move all my little boxes around so I can get to where I need to go. So again, before we get started, we do want to recognize that University of Wisconsin is built on Ho-Chunk Nation land. And so we always want to recognize that we're appreciative to our Ho-Chunk tribal leaders and for their partnership with us and helping us to better understand their history. So today's session is facilitated by the Wisconsin Alzheimer's Institute, also the NIH-funded Alzheimer's Disease Research Center, and also the Wisconsin Medical Society, who's helping with our educational accreditation. And again, as part of this educational session today, it'll be approved for AMA credits. And so those in control of contents are required to make disclosures. So again, we really want this to be evidence-based information that you're receiving and not driven by other conflicts of interest. So we have disclosures that we'll share with you so that you can judge if there's any bias. And we do want you to let us know if you do note that in any of this educational materials. As we talk about the planning committee and disclosure statements, I do want to really take this time to thank colleagues. So there's a lot of thought that goes into this presentation. So we have amazing speakers lined up for today and tomorrow. All the work that goes into their preparing for these presentations, all the patient ideas and caregiver ideas that they integrate into their presentations as well. But also want to thank the planning committee. So Tammy Albrecht, who's a nurse practitioner with our program, Sarah Klein, who's our Wisconsin Alzheimer's Institute administrator, Jody Craner, who I think many of you know. Jody is our Dementia Diagnostic Clinic Network Manager, and she is really the mastermind behind this conference. And again, leading the initiatives, setting up and organizing things in a way that makes everything run smoothly. So really thank Jody for her time. And Dr. Maria Mora Pinzon also is a preventive medicine physician who does a lot of our work with our clinic network team. And so she also is on the planning committee, as well as myself and Dr. Walasek. Dr. Walasek is a geriatric psychiatrist here at UW, and as many of you know, is an amazing educator. So these are the disclosure statements. So again, the first four program participants do not have disclosures. I am a study investigator for the AHEAD study, which is an Alzheimer's prevention study. So we receive grant support here for that, although I do not receive any financial incentives myself. I also help support another Alzheimer's prevention study called the A4 study. So I'm a site PI for that, and same situation. And then we received a medication for one of our VA studies from Amarin and from a VA sponsored study. And then Dr. Walasek has written a book and receives royalties for his great wisdom in the field of behavioral challenges in persons with dementia. But also behind the scenes on this, we have amazing communications team. So Claire Bittner, Navina Jaspel, and then Sarah Klein and colleagues have really stepped up and helped us with developing the outreach materials. And then Dr. Tammy LeCare has also really helped with helping do evaluations and helping formulate this conference. So there are many other colleagues who are involved, but I just want to name those as a few. So for our presenter disclosure statements, again, neither Dr. Bouges or Dr. Bukowy or Dr. Radue have any disclosures. And as I mentioned before, I'm site PI for 2 studies that are co-sponsored by pharmaceutical companies and receive study medication from one from my VA-based study. So for our agenda today, we're really excited to welcome Dr. Shenikqua Bouges, who will be speaking on diagnosis and management of dementia. So again, we really like to make sure that we're getting the bases, making sure that we all feel comfortable with the foundations of dementia care. And it's important because dementia care is going to be transitioning probably in the next 10 years. You know, we've had these same medications, same approach to dementia care. We really hope that there'll be better treatments for persons with dementia due to Alzheimer's and other causes, that will better understand early detection techniques in our clinics, that will have better ways to support caregivers and families and more interlinked research and clinical opportunities, and so that people feel more supported in this journey. And then related to that, Dr. Bukowy from Medical College of Wisconsin will be speaking next on difficult conversations around palliative care. So again, we just had a big meeting on this for the National Alzheimer's Project Council and recognize the importance of palliative care and identifying goals of care with patients and their families, that it's not just a one-size-fits-all approach to diagnosis and management. And then we'll have Dr. Rebecca Radue speak to us about late life substance use disorders and cognitive impairment and dementia. And again, with increased cannabis being available for in different states, I think there's increased use among our patients who are having cognitive impairment in addition to other substance use. And so I think helping us as clinicians to really feel comfortable in how to approach diagnosing and managing these disorders that contribute to cognitive decline is really important. And then we'll finish up with some closing remarks and get ready for tomorrow's sessions as well. All right, so before I introduce Dr. Bouges, let me just ask Jody, is there anything else you want to talk about? We will have the presentations and the recordings will be available on our website November 18th. When you receive an evaluation, which will go out on Friday night, so Friday afternoon after all the sessions, then you'll be able to sign up for credit, for educational credit.
You covered it all. Great job.
And you all know, and I'm just going to admit this out loud, that Jody's really, I just show up and put on a red jacket and Jody does all the, not just Jody, our team does all the work. So I really appreciate what a great team effort this is. We have a great group of people we're working with. And so with that, I am thrilled to be able to introduce my colleague. So Dr. Shenikqua Bouges is an assistant professor of medicine here in the Division of Geriatrics in our School of Medicine and Public Health. She also is a clinician at the Madison VA Hospital. She's an amazing colleague. Her clinical interests include diagnostic memory assessments, dementia care, and geriatric medicine. She's a memory care physician, as I mentioned, at the VA, but also at UW Health Fitchburg and East Clinics. And she also conducts research in trying to look at the effects of metabolic dysfunction on cognition and developing a variety of alternate recruitment techniques to engage people from diverse backgrounds into clinical research. So I am thrilled to introduce Dr. Bouges. She's an amazing clinician and just really thrilled to be able to hear from her today as she shares with us how to approach the diagnosis and management of persons with dementia. So I will stop sharing and let Dr. Bouges share her slides. Welcome, Dr. Bouges.
Thank you for that introduction, Dr. Carlson. Can you hear me okay?
Yes, we can hear you and we can see you as well. Great. And I'll give you, as you requested, I'll give you a 5-minute warning before we're done.
Okay, thank you. And once again, I'm Shenikqua Bouges, a geriatrician at University of Wisconsin in our Madison, VA. And so today we'll talk about, our discussion will be on the diagnosis and management of dementia. And so just to start off, I have no financial relationships to disclose. And then just want to start with some common terms that we'll talk about throughout this discussion. So mild neurocognitive disorder, also known as mild cognitive impairment or MCI, and a major neurocognitive disorder, people commonly like to call dementia, and then amnestic, specifically referring to our neuropsychological testing when individuals have deficits only in cognitive measures of memory. So learning objectives, we'll review the diagnostic criteria for MCI as well as dementia and discuss the clinical workup for dementia as well as the management of dementia. And so just to start off, I want to discuss what normal aging is like, because as we all get older and wiser, we expect things to slow down. So that's a decline in our ability to process information, retrieve memory for a longer period of time, as well as focus in conversations and our ability to multitask or organize information. Mild neurocognitive disorder based on the DSM-5 criteria is based on cognitive decline or change in memory from a subjective history by either the patient, family member, or provider, but also objective findings of cognitive decline based on neuropsychological testing. But these individuals continue to remain functionally independent in their instrumental activities of daily living, like medication management, financial management, shopping, driving, their use of technology or managing medical appointments, as well as their activities of daily living. These deficits are not due to delirium and can't be explained by another mental health disorder. As opposed to a major neurocognitive disorder, the main distinguishing factor is with dementia. These individuals now are having impairments with their functional abilities. So trouble with medication management, shopping, technology. As they progress, they'll start to show difficulties with their basic activities of daily living as well, like bathing, dressing, transferring, ability to feed themselves, as well as maintain their bowel and urinary continence, and also can't be explained by delirium or another mental health disorder. And just wanted to give the DSM-5 criteria for delirium as well, which is going to be an acute change in the individual's attention or awareness, and it's a change from baseline, and it tends to fluctuate within a short period of time, can be within hours or days. So you come see a patient in the morning and they're very sleepy, out of it, come back later on, they may be clearly alert. And so that's an acute change in their cognition, and it fluctuates throughout the day. It's not explained by pre-existing or establishing underlying neurocognitive disorder, but may be a direct effect of another medical condition or substance intoxication, or if someone has an extreme infection or dehydration, etc. And so going into the diagnostic workup, and so initially, individuals who present with memory loss are going to first show up in primary care. Either the patient comes in with a concern with memory loss, family members, or the primary care provider themselves is noticing the patient who's been well managed from a medical standpoint throughout life. Now, all of a sudden, is starting to have uncontrolled blood pressure, or their thyroid level is not well controlled. If they have hypothyroidism, doesn't seem like they're able to follow through with medical recommendations, mixing up appointments. So that would be an indicator to administer a cognitive screen. And so based on that cognitive screen, if it's any concerns for abnormal cognition, then doing an initial workup while placing that referral. So lab work as well as structural imaging, either a CT or MRI of the brain, typically MRI of the brain, so we can evaluate for any concerns of vascular disease. However, if an MRI is contraindicated in that patient, a CT would be fine. And so then refer to our memory diagnostic clinic or memory specialist so they can have the formal neuropsychological testing done as well as any additional workup that may be needed. And so just to discuss the cognitive screens, typically recommended during an annual Medicare wellness exam for any individual who's 65 years of age and older. And sometimes a separate visit may be needed because depending on the type of screen, it may be a little longer. But if you're pressed for time, a mini cog, just a simple questionnaire, clock draw, as well as trying to test recall can be done in about 5 minutes. The MOCA usually have to pay for this test, but slums can be easily accessed online and is better at detecting mild cognitive impairment as well. And it's usually 15 to 20 minutes. And so with the diagnostic workup, it's lab work, assessing for any concerns of vitamin deficiencies, your B12, thiamine, if it's someone with heavy alcohol intake, vitamin B6, vitamin D, looking at their folate level as well, checking TSH level, blood count, also chemistry, checking for any concerns of electrolyte abnormality or renal dysfunction, also medication review, especially making sure the individual isn't taking any PM medication, so Tylenol PM or Advil PM, because a lot of patients are not aware that that contains Benadryl. Depression or anxiety screen just to assess mood. So that can be worked on while the patient is being referred to a diagnostic clinic if it's any concerns for abnormal memory. Risk stratifying those individuals for concern of sleep apnea as well, because that's been a biggie that we see a lot of structural imaging, CT or MRI of the brain, and then more functional imaging we'll do if needed once the patient sees us in memory clinic. And that'll allow us to just get a better differentiation, especially when trying to distinguish between Alzheimer's disease and frontotemporal dementia. And so some common, just going through some neurocognitive disorders. This first slide is showing some of the more common neurodegenerative diseases, excluding vascular dementia. And then also some more neurocognitive disorders that we may see. And then some more reversible causes of those neurocognitive disorders like your depression, electrolyte abnormalities, thyroid disease, medication, side effects, vitamin deficiencies, just why it's good to try to work them up as soon as we can. Autoimmune diseases can affect cognition as well. So just going through some of the common neurocognitive diseases, with Alzheimer's disease being the most common neurodegenerative disorder, and it's the 6th most common cause of death in the US, with age being the greatest risk factor. When you have individuals presenting earlier than 65 years of age, then that's more likely associated with a gene mutation, which typically tends to be autosomal dominant inheritance, and that's with your amyloid precursor protein or your presenilin 1 or 2. And so with Alzheimer's disease, it's just a gradual, slow progression of cognitive decline, typically presented with memory difficulties initially, depending on when that patient presents to clinic, 65 years of age and older. Common deficits showing up on neuropsychological testing is with their memory and language cognitive domains first, and some typical findings that we may see on imaging is atrophy in the mesiotemporal or hippocampal area. And with the FDG PET scan, you'll see hypometabolism in that temporal parietal area. But also keep in mind, even if you don't see these findings on MRI or CT, it doesn't rule Alzheimer's disease out. It just may be too early in the disease process. Vascular dementia, second most common neurocognitive disease, can occur at any age, but you have increased prevalence after the age of 65. Risk factors, vascular disease, hypertension, very common, hyperlipidemia, someone have diabetes that's not well controlled, or chronic history of diabetes, sleep apnea, especially if sleep apnea is not well controlled. Cerebral amyloid angiopathy increases your risk, as well as CADASIL, which is a cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, because these individuals are at increased risk of having multiple strokes. So that increases their risk for vascular dementia. And they typically have some concerns with mood changes as well, like depression or apathy. With vascular dementia, you're looking out for a history of stroke related to cognitive decline. And so with vascular dementia, that's more of a stepwise decline with focal deficits, depending on where that individual is having injury in the brain. And when we say stepwise, that means typically you look for that individual to be stable, or they can be stable as long as their risk factors are well controlled. But each time they have insult or injury to the brain from a vascular standpoint, then they're going to decline more from a cognitive standpoint. And white matter lesions, as well as lacunar infarcts, are common with cerebral small vessel disease. Some common deficits that show up on neuropsychological testing is difficulty with speeded task, as well as some executive dysfunction. So may have some difficulty with trails making test B or clock draw. May have trouble with animal fluency as well. On neuroimaging, may see infarcts, hemorrhages, or white matter hyperintensities, especially if it's a concern for cerebral small vessel disease. Frontal temporal dementia, this is the second most common type of dementia for early onset disease. 50 to 60% of cases are sporadic, but in that other 40% is typically due to genetic mutations from an autosomal dominant pattern. I grouped it in two larger categories. So two variants, behavioral and language variants you could have. And depending on the type of variant you have, learning or memory tends to remain intact initially in the disease process, as well as their perceptual motor function. On imaging, you're looking for atrophy in the frontal and temporal lobe regions. And this is also an insidious gradual onset, but the age of onset tends to be a lot earlier. And with the behavioral variant, you're looking for 3 or more characteristics where the individual starts to display personality changes. They're more disinhibited, maybe express some apathy, loss of sympathy or empathy, more repetitive stereotype behaviors, increased appetite or dietary changes. With the language variant, these individuals tend to present more so with speech difficulties as the initial concern. And you can have different types, semantic variant, where they have the inability to understand the meaning of words, or agrammatic non-fluent variant where speech just doesn't make sense, grammatical errors when they're speaking. And with the locopenic variant, the individual has an understanding of words. However, they have difficulty being able to retrieve that information. So they know what they want to say, but they have difficulty getting the words out. And the locopenic variant tends to be associated with Alzheimer's disease. Lewy body dementia groups dementia with Lewy bodies as well as Parkinson's disease, but the distinguishing features is with dementia with Lewy bodies, you're looking for cognitive decline that occurs approximately a year prior to those motor symptoms or Parkinsonisms, as opposed to Parkinson's disease. Those individuals have motor symptoms years prior to displaying any cognitive decline. And so at least 10 years prior, they present with the motor symptoms followed by cognitive decline. And then that would be concerning for Parkinson's dementia. Second most common cause of dementia, Lewy body dementia of the neurodegenerative diseases. Common features, cognitive impairment, motor dysfunction, behavioral changes, autonomic dysfunctions or orthostasis, urinary incontinence is common. Sleep disorders, if they have REM sleep behaviors, restless leg, may have sleep apnea. And it's also a gradual insidious onset, but you're looking for a fluctuation in cognition with pronounced variation in their attention and alertness. So at one point, it seemed like they're very impaired from a cognitive standpoint and then improve later on, but also looking for other features so it's not mistaken for like delirium, because these individuals will also have recurrent visual hallucinations can be animals or small people, very clear visual hallucinations. On neuropsychological testing, they tend to have impairments in visual spatial perception, executive function, memory varies, attention and psychomotor speed. With imaging, you're looking for hypometabolism in the parietal and occipital areas. And I included traumatic brain injury as well because it's very common, 1.7 million cases annually, more common in males, with the most common etiology being falls, which is very common in our geriatric population, a car accident, as well as being struck on the head. And recovery from traumatic brain injury is variable depending on the type of injury, age, and if it's any prior history of damage, because repetitive injury is going to cause greater insult and can cause greater cognitive decline as well. And substance use also factors in. And so evidence of one or more of a loss of consciousness, post-traumatic amnesia, disorientation, and confusion are neurological signs following traumatic brain injury, like headaches, dizziness, etc. On testing, it may have deficits in complex attention, executive function, learning, and memory. And you could also have disturbances in your emotional function and personality changes as well. And so this table just summarizes some of those common neurodegenerative disorders, highlighting the fact that Alzheimer's disease is the most common. Age of onset is at 65, gradual progression with memory and language being the common or initial cognitive deficits, as opposed to frontal temporal dementia, earlier onset. You're looking for behavioral or language variant. And vascular dementia can occur at any age, and it's more of a stepwise progression as opposed to that gradual progressive decline over the years in the other three. And then dementia with Lewy body, still a little younger than with Alzheimer's disease, and you're also looking to see if it's any Parkinsonian symptoms, as well as any concerns of visual hallucinations. Acetylcholinesterase inhibitors, which we'll talk about more, can be used for all of these except for frontal temporal dementia. But sometimes in cases when you have the language variant, specifically locopenic, which tends to be associated with Alzheimer's disease, some individuals are able to tolerate the acetylcholinesterase inhibitor in those particular cases. And so management, pharmacological treatment, the acetylcholinesterase inhibitors are what we start with first. Typically, donepezil is FDA approved for all stages of dementia, whereas rivastigmine and galantamine are for more mild to moderate stages of dementia. And then memantine as NMDA receptor antagonist, this FDA approved for more moderate severe cases. However, if we have patients, because not all patients present the same, where the acetylcholinesterase inhibitors are contraindicated, sometimes we start the NMDA receptor antagonist sooner. Some non-pharmacologic strategies, lifestyle changes. So diet, stressing the mind diet, which is a combination of the Mediterranean and DASH diet, stressing your extra green leafy vegetables, fruits, specifically berries, lean meats, whole grain products, limiting intake of red meats, processed foods, sweets, and cheeses in moderation. Stress and moderate intensity exercise, 25 to 30 minutes, 5 days a day. But that will also be dependent on the patient, because if it's someone who's pretty deconditioned, would recommend they work with physical therapy first to find exercises that's safe for them, but then also scale back and maybe aim for 10 to 15 minutes at a time until they're able to build up their endurance. Sleep, stressing 7 to 9 hours. For our geriatric patients, and then brain stimulating activities, reading, if they play an instrument, continuing to play that instrument, learning a new task, jigsaw puzzle, crossword puzzles, word search, any activity, board games, card games, just to keep the brain active every day. And socialization is going to be very important for the individual as well. Making sure we address any sensory concerns. So if it's a concern with hearing loss or vision loss, making sure the individual sees audiology and have their regular ophthalmology visits as well. Symptom management based on mood, especially with frontal temporal dementia, you're just treating symptoms. If there's any concern of depression or apathy, treating those with antidepressants. We sometimes start with SSRIs first, start low and gradually titrate up as tolerated. Sleep, working on sleep hygiene, melatonin, and then advancing with the therapy as needed. While still trying to weigh the pros and cons and trying not to provide anything that may impact cognition if we can. And then antipsychotics for more of a last resort, if it's a concern of dangerous behavior that may affect the patient or family members. And so I just want to wrap up with 3 cases. So first case, 72-year-old accountant, past medical history, chronic history of depression. They present to their PCP with the concern of difficulties expressing thoughts, forgetting what he's saying mid-sentence, and forgetful of recent events as well as details. He was unable to do calculations in his head and noted making the wrong turn while driving. It's been taking longer for him to think about information, and his gait has started slowing down as well. His wife also notes a gradual decline in these symptoms. Family notes word retrieval difficulties, some short-term memory loss, forgetting recent conversations, and all of these changes are significant change from the patient's baseline. And so medications, he's just taking an antidepressant. His lab work was insignificant. Physical examination was insignificant as well. Review of symptoms, insignificant. His functional assessment, this is an accountant, but he was scammed out of $50,000. He's starting to forget to pay his bills on time, and he's missing appointments. On neuropsychological testing, he was noted to have deficits in learning new information as well as his short-term memory loss. So his deficits are in memory. So amnestic profile, his instrumental activities of daily living, he's impaired with medication management, finances, as well as appointments. He scored a 15 out of 30 on his MMSC. So he has functional impairments. He's noted to have deficits on testing in his memory domain. So amnestic profile, he meets the criteria for a dementia. Of course, you have to do additional workup as well. And so this is showing his R-band, similar to what we discussed. So he's impaired with his immediate memory of learning new information, borderline impaired with short-term memory. And then on MRI of the brain, just highlighting where he has some cortical atrophy, but some significant atrophy of his hippocampi. which is classic for Alzheimer's disease. Atrophy in that temporal area as well. So the next one, 73-year-old male executive with 18 years of formal education comes in with forgetfulness of recent information, word retrieval difficulties, or trouble finding the words in conversation, trouble expressing himself. He also notes trouble doing simple calculations, takes him longer to think about things. He's making the wrong turns with driving. His wife notes slow progressive decline, but his functional abilities tend to fluctuate over hours and days. He has a family history of dementia, and his sister and maternal uncle in their 60s, so earlier onset. With sleep, he's having some difficulties, yelling, cursing, and shaking limbs for the past 9 years, so some REM sleep behaviors. Also has a diagnosis of moderate sleep apnea and is using CPAP for that. Also note some visual hallucinations of small children in his room who are stealing from him. And from a mood standpoint, he stopped socializing, exercising, or going out. Medications, he's only taking vitamins. Blood pressure was a little elevated, 160/85 sitting and 107/65 while standing. So he's orthostatic. On physical exam, he's a little bradykinetic, tiring with finger tapping. He has symmetric postural tremor and a shuffling gait. With review of symptoms or systems, he notes lightheadedness and near syncope when standing. With his instrumental activities of daily living, he's getting lost, and he had an accident about 2 months ago. His labs are within normal limits. On his MMSC, he scored a 25/30 with poor performance on his intersecting pentagons. So some visual spatial difficulties. With testing, his memory is okay. His immediate memory is in borderline impaired and just low average. With short-term memory, attention, visual, spatial, and language is fine. He does have delayed processing speed on his trail making test A. It took him longer, it's impaired, and then borderline impaired with trails making test B. So a little bit of difficulties with his executive function, visual difficulties, as well as delayed processing speed and some Parkinsonian-like symptoms. And so with this patient, imaging showing MRI at 73, and then 2 years later, just to highlight the fact that yes, he does have mild atrophy, cortical atrophy, mild atrophy of his hippocampi, but it stays stable over 2 years, which we wouldn't expect this to occur if the patient had Alzheimer's disease, because you expect things to continue to progress and him to have more significant atrophy in this area. And so this patient met criteria for dementia with Lewy bodies. He had some REM sleep behavior disorders, Parkinsonism. He was orthostatic, fluctuations in his arousal, and had some visual hallucinations and his mild cognitive impairment. Last case, 77-year-old female with hypothyroidism, hypertension, hyperlipidemia, coronary artery disease, as well as type 2 diabetes mellitus. She presents with short-term memory loss, word finding difficulties, as well as starting to miss some medical appointments. She has a strong family history of cardiovascular disease in her parents, as well as 3 siblings. On review of symptoms or systems, she notes constipation, fatigue, headaches. She has extremely dry, flaky skin. Her mood is pretty apathetic. She has poor sleep, getting about 4 to 5 hours, naps for about an hour a day. She snores, has apneic episodes, and notes restlessness the following day. Medications that she's taken: amlodipine, levothyroxine, metformin, as well as atorvastatin. From a functional standpoint, she's independent in her instrumental activities of daily living, as well as her activities of daily living. Vitals, her BMI is 40. Her blood pressure is elevated at 175/92. Heart rate is 55, so a little bradycardic, but she's asymptomatic. Sat in 98% on room air. On physical examination, she looks disheveled. Her skin is very dry. She has poor skin turgor, slow responses to questions, as well as some word retrieval difficulties. Her lab, she's anemic. Her creatinine is elevated, BUN creatinine. Not sure if she has a history of renal disease. Didn't look like it based on her history, so maybe dehydrated, as well as with the skin turgor. Her B12 is low at 157, and her TSH is elevated. A1C is 6.5. On her MRI of the brain, she was noted to have scattered hyperintensities, which is advanced for her age, so a concern for small vessel ischemic disease, as well as an infarct in her temporal region. She scored a 25 out of 30 on her MMSE and a 10 out of 15 on the GDS. And then with her testing on her R-band, she was impaired in her memory, so learning new information, as well as her short-term memory. And she did a lot worse with immediate memory as opposed to with her short-term memory. Her processing speed, just low average. Trails making test B was low average as well. And so the reason why I highlighted this particular case is because this tends to be the type of patients we see in clinic. It's never going to be not often are you going to have a straightforward patient where you come up with a diagnosis in one visit. Typically what happens is the patient first needs to be optimally managed from a medical standpoint before getting a better idea of what's going on. From a cognitive standpoint. So with this particular individual, she has subtherapeutic hypothyroidism, moderate depression, uncontrolled hypertension, high risk for sleep apnea with a stop bang of 6, a concern for dehydration. She has B12 deficiency, concern with her nutrition, as well as increased vascular disease with a remote infarct noted on imaging. So all of these things need to be addressed before we can really get a good idea of what's going on. And it says she's functionally independent, but even if this individual was having some difficulties with her instrumental activities of daily living, it would be kind of challenging to give her a diagnosis of dementia with so many complicated comorbidities. And so correct the underlying etiologies and then have the person come back for retesting to see if it's a concern for an underlying neurocognitive disorder. And it'll take time to get her comorbidities more under control. In this particular case, now the individual's immediate memory is right at that average range, and short-term memory is at low average range. And so in summary, early diagnosis is key. Screening individuals in clinic, especially if it's any concern with memory loss or that things may be changing in that patient, try to rule out those reversible factors prior to having them referred or in the process of referring them to clinic. Do a neural imaging as well. So that structural imaging to look for anything that may be concerning. Refer the individual to our memory diagnostic clinic so they can have the formal neuropsychological testing and any additional workup if needed. Thank you for your time, and I can take questions.
Thank you, Dr. Bouges. That was so helpful. It was an excellent overview of good quality dementia care. And the cases are great examples of how we can make a difference by addressing some of these medical problems, which we see all the time in our patients. Maybe while we're waiting for questions, I'm wondering, I know that you and Dr. Fisher, just from my personal experience, do a great job of helping people with some of these lifestyle factors, so the mind, diet, exercise. And I'm wondering if you could speak a little bit more to that. Like, how do you approach encouraging patients with different abilities to make these lifestyle changes?
Good question. Usually is depending on the patient and where they are as well, especially with exercise, because sometimes that's a challenge, especially with chronic pain. So offering other alternatives. A lot of senior centers have exercise classes where they can do chair exercise. If walking is too difficult for them, stationary bike. And if it's a concern with mental health concerns, some individuals are not willing to speak to a therapist, don't want to start medication. So we recommend some of those mindfulness strategies to help from that standpoint, just trying to figure out where the patient is and find things that they would be willing to work on, but also telling them to take baby steps. So change one thing at a time and praising them when they do make a positive change.
Thank you. All right, so we do have some time for questions. Dr. Bouges did awesome and staying on time. I didn't have to do my reminder even, and got through a lot of great material. So if you have questions for Dr. Bouges, if you want to put those in the Q&A section. And while we're waiting for those, unless someone else has a question that pops up, I'm wondering, Dr. Bouges, could you just touch base on how do you think the care of patients with dementia is going to change in the future? Like, what are some of the key things you see? I mean, I know we are at the verge of new medications and biomarkers and things like that. Can you speak to what we can do as clinicians to help prepare ourselves, get ready for some of these future changes?
I think as clinicians, maybe biomarkers is going to become bigger, because I know now it's just mainly on the research side, but thinking more so in regards to clinic, checking some of those biomarkers. I know they're still trying to look on finding a blood test as well that would be least invasive. So that would be nice if we could find one that comes along the pipeline. That would help out a lot in clinic as well. And then thinking about the newer therapies that are coming out also.
Other questions for Dr. Bouges? I think we're going to try, again, we're continuing to learn with our educational formats. I think we're going to try to let people raise their hands and then let you talk. If you have a question for Dr. Bouges, you can either put it in the Q&A or raise your hand and we'll unmute you. Maybe while we're waiting to, Dr. Bouges, could you speak to how do you best, oh, let's see, I don't want to usurp this. Okay, so I think Beth Ann Murkowski has a question. See, Jody, are you able to unmute her?
You should be able to talk now.
Okay, I just unmuted too. Thank you. Hi, I'm Beth Ann Rakowski, and I'm the Dementia Care Specialist in Taylor County for the ARDC. And thank you for the wonderful presentation. A question that I have is hormone testing for thyroid, hypothyroidism and everything. Has there been any research on testing other hormones from that the thyroid, related to the thyroid, like, you know, reverse T3 for T3 levels, all those things?
Great question. So if I understand you correctly, you were asking if there's any other research on other hormones or levels to check in regards to thyroid disease. I know depending on what type of thyroid disease the individual has, typically with hypothyroidism, if the person is being managed with medication, we usually just check the TSH level. But sometimes what happens also with individuals, if they're not taking medication, what we've seen is if they have a TSH level, which is marginally normal, sometimes checking the T4 or T3 level to see if it's elevated or if it's indicated any concern, because despite the TSH level being marginally normal, something else may be going on, especially if the individual is not taking medication that's impacting that level. So from that standpoint, that's when we tend to look at the free thyroid, the free T4 and T3 levels as well, to get better clarification on what may be going on. Because in some cases, I know we had one patient that was more subclinical, but there was more a concern of hyperthyroidism. And we had to check the T3 and T4 levels to get a better idea. And mainly because sometimes we go to the free T4 or the total T4 level and forget about T3. And in this particular case, we recommended checking the T3, and that level indicated what was going on or the concern for that in particular patient.
That was exactly what my experience has been too. My own mom and several of my patients that had ended up with dementia. My mom ended up with strokes, but all with dementia or Alzheimer's, and their TSH was okay, but the other levels were not okay. So that it's interesting to hear that there is testing on that. So thank you.
You're welcome. And then sometimes what happens also is you may have an individual who has hypothyroidism and they're taking the levothyroxine and their TSH level says normal, but it's marginally normal and it's under 1. And typically we recommend, especially if you're taking medication to control that thyroid level, then you want them within that normal range and being greater than 1, not less than 1.
Right. And now, as you just said, that makes me question too, with somebody who doesn't have a thyroid and doesn't produce any T3. So doesn't Synthroid not have T3 in it? And if you don't convert your own, is that right? So they wouldn't be producing any T3, which would mean that the reverse T3 levels would be low.
Mm-hmm.
Is that correct?
Yes, I believe so.
Thank you very much.
You're welcome, and thank you for the question.
If you have questions, you can feel free to raise your hand. Otherwise, Dr. Bouges, could you just speak to how do you help integrate caregivers into your plan for your patients? So I know that caregivers come in with their care partners. They come in, and frequently I think we diagnose them and then send them on their way. So how do you approach engaging care partners in kind of the management plan?
Good question. And so I'll just repeat the question first. How do we integrate caregivers into the care management plan? And so typically, and thankfully, what I like about the interdisciplinary approach that we take with clinic, the caregiver or provider is usually there during the visit. So I include them in the plan from the beginning, and especially if they're more actively involved, if they're in a separate household, making sure they have 2 copies of the patient instructions, but also following up with those patients, especially once they get a diagnosis of dementia. We continue to see them from a longitudinal standpoint and try to follow up with them within 2 to 3 months. And each time the patient is coming back for a follow-up visit, I want to know how the patient is doing, but also how is that caregiver doing, especially as the patient is starting to progress, trying to identify any concerns for caregiver burden and making sure they're staying in contact with the social worker and know all about the resources that they have available. And we go through that with the initial visit as well, making sure they do know that there's resources available if they need it, as well as information.
Thank you. I think we're waiting to see, is Dr. Bukowy on? I think we're looking to see if she's on yet.
I do not see her on yet. She did have a very busy schedule. I just did send her a text.
Great. Okay, thank you. And is Dr. Radue on yet? Probably not for.
Yes, I am on.
You are on. Dr. Radue, would you mind going next? Does that work for you?
Yeah, that works just fine.
Okay, so we will switch gears because we are so flexible because of COVID has trained us well. But first, I just want to thank Dr. Bouges for her presentation. Again, we really hope to help people get a good grounding and feel very comfortable with the basics of what dementia is, what it's not, differential types of dementia. And I just appreciate how much you went through in the short time we gave you. So thank you so much, Dr. Bouges, for your presentations and for answering our questions. So we are going to move on to our next speaker. We are thrilled, again, I'm so thrilled to be able to work with many of these colleagues. And even though Dr. Radue is a fellow with me, I think I learned more from her than she probably did from me in memory clinic. So Dr. Rebecca Radue is a geriatric psychiatrist at the William S. Middleton VA Hospital, where we work. And she's board certified in geriatric psychiatry, and again, received her doctorate of medicine here at UW, School of Medicine and Public Health, and also completed geriatric psychiatry residency and fellowship at UW. She enjoys working with older adults with substance use disorders and those living with dementia and their families. She also is very involved with teaching, education, with academic medicine and the community, and she's a clinical adjunct assistant professor at UW as well. So again, I've learned a ton from Dr. Radue in clinic about late life substance use disorders and cognitive impairment and dementia. So we're thrilled that she'll be able to present to us today. So welcome, Dr. Radue.
Thank you so much, and thank you for having me. So let me just get into my PowerPoint here. So yes, thank you so much. So I have no financial disclosures to make, but I will be discussing off-label use of psychiatric medications for substance use disorders treatment in older adults. And so these are our objectives. So we're going to be describing the prevalence of substance use disorders, kind of what we're looking at in this country. And spoiler alert, they are increasing amongst older adults. We'll talk about how substance use can impact cognition and also the risk for development of neurocognitive disorders like dementia. We're going to appreciate the complexities of identification and treatment, and we're going to be talking about ways to screen, ways to treat older adults with substance use disorders. And we'll be able to apply these evidence-based guidelines that I'll be kind of talking about to treat older adults. So no surprise, substance use disorders are a growing problem amongst older adults in the United States. So I have these statistics. These are actually a bit older. So I have a star by the 2018 National Survey on Drug Use and Health. There is a 2020 version available, and the data can be kind of sifted through and sorted through, but it hasn't been analyzed to look specifically at older adults as of yet. So in 2018, there were nearly 1 million older adults with a substance use disorder. And they had been increasing amongst older adults compared to prior years. At that time, roughly 65%, so a majority of older adults, reported exceeding alcohol intake recommendations weekly. And roughly 10% reported binging 5 or more drinks in a sitting. So those are quite significant, and that has only increased, especially during the pandemic. And then another statistic here from 2013 to 2015, again, quite an old statistic, but not much newer is available. The population of those 55 and over grew by only 6%, while that population seeking opioid use disorders treatment in that age group, age cohort, increased by 54%. So very significant. We know that older adults are not immune to the opioid epidemic. So very significant there. I'd be remiss in addressing the WAI if I didn't talk about caregiving. So we know that caregiving is a risk factor for development of a late life substance use disorder. We also know that caregivers are at risk for earlier mortality, burnout, depression, all kinds of negative outcomes. We also know that caregivers of those with late life substance use disorders face these really difficult challenges and stresses. And They may have, however, survived resiliently for decades with their loved one's substance use disorder. Certainly their loved one may have developed a substance use disorder in late life, but if they developed it in earlier life, they may have kind of wrapped around that person, and the dynamics can be really challenging to unravel. And certainly intimate partner violence and elder abuse can be at play as well. Definitely things to be thinking about when we're talking about substance use disorders in late life. And of course, cognitive impairment, no surprise here, but it can really complicate things. So, alcohol use disorder is the most prevalent substance use disorder in late life. That's probably no surprise to anyone. It's the most prevalent substance use disorder at any age. Alcohol is pretty freely available, and unfortunately causes a great deal of harm in our society in terms of morbidity and mortality. Risky alcohol use amongst older adults is a growing problem. So, risky drinking amongst older adults in the US grew by 65% from 2001 to 2013 and has only continued to grow. While men are more likely to engage in risky drinking is actually growing faster amongst women. So older women are actually more likely to develop problems with alcohol, which is very interesting and something really, I think, to think about. I think caregiver burden has a lot to do with that. And of course, we know that that women tend to live longer and face kind of the stresses and pressures of added grief and loss as we age. We know that isolation, especially with the pandemic, is a huge risk factor for developing a late life substance use disorder. So talking about alcohol, I did want to talk about alcohol withdrawal. So you can see here over on the right-hand side, I have the symptoms of alcohol withdrawal syndrome. And so here's time of appearance after cessation. Of course, we're most concerned about delirium tremens and seizures, which are kind of the scariest complications of alcohol withdrawal. And an important thing to know is that for older adults, the onset of these set of symptoms can be pushed out a bit. So, we're talking about alcoholic hallucinosis, 12 to 24 hours typically, but it may be pushed out a bit for an older adult. Because it may take them a bit longer to clear the alcohol from their system. So we may be looking more at like 18 to 36 hours instead of 12 to 24. So that's something good to know. Another really important pearl is that confusion may be the predominant clinical sign. So initially, we may see people in the ER, the emergency department, or you may see people in their homes, and rather than having initially tachycardia or tremor or nausea or sweating, they may have confusion as the predominant clinical sign. And so I think that's really important to keep in mind. And then there's a direct relationship between the duration of withdrawal and the level of alcohol consumption. That's probably no surprise to anybody. And folks may even be going into withdrawal when they still have a blood alcohol level that's relatively high, depending upon how long they have been drinking. But generally, overall, older adults are at a greater risk of complication from alcohol withdrawal. So we really want to be considering admission. This is a potential life-threatening emergency. Of course, as you know, and as I know, we can't always admit everyone, right? Like sometimes it's just not feasible, especially when we're talking about cognitive impairment. Somebody may do really poorly if we're admitting them for alcohol withdrawal, and they have a dementia on top of that. They're at risk of becoming a bit delirious. As you can imagine, I'm just envisioning, the internal medicine attending, telling me in the ER, my goodness, this person's going to have so many code oranges, like the behavioral code. And so it may not be feasible to admit somebody. So that's something to be thinking about. So talking about opioid use. So just prescription drug use and abuse in general, I think most older adults who didn't, live with an opioid use disorder from their youth are becoming addicted to opioids from prescription use. Older adults are more likely to need like orthopedic surgeries, dental surgeries, the kinds of procedures where we give short-term opioids. And these drugs are very powerful at harnessing the pleasure reward pathway. And if somebody's pleasure reward pathway is genetically primed or primed from earlier life experiences to, get sucked into addiction, that can really happen. And so just something to be thinking about. So older adults are the population at greatest risk for prescription drug abuse. And we're not just talking about opioids or traditional drugs of abuse. I have had folks misusing or abusing benzodiazepines, muscle relaxers. That's probably no surprise to anybody. Gabapentin, pregabalin, antihistamines. I have seen some of that. Some folks who were misusing diphenhydramine, like in really high doses. It can be intentional or even unintentional, right? An older adult with cognitive impairment may forget that they've taken their medication for the day and may be taking more than is prescribed. I definitely have a number of older adults who are on kind of chronic benzodiazepines, and that's always a concern. I'm always monitoring how are they doing. And I think when cognitive impairment comes to play, you have an unbefriended elder who's still doing their own medications. They may, come into some real difficulty there with these controlled substances, forgetting that they've taken them. Older adults are also at risk for diversion or exploitation. You think about the child or the grandchild with an alcohol use, or sorry, not alcohol, a child or a grandchild with a prescription or illicit drug use problem, and maybe accessing their grandparents or parents' medications. I definitely have had that happen to some of my patients. So opioid misuse is a growing problem amongst older adults. So this is, again, an older statistic, but like I said, not much new is really available, which is challenging for us, I think. So between 2000 and 2012, heroin use increased 26% in older adults, but non-prescription methadone increased by 200%, and other opiates and synthetics increased by 221%. So my goodness. I think when older adults use opioids, illicitly, they're tending to prefer, things that are quote unquote safer, like methadone or Suboxone, obtaining illicitly, which is a shame, right? Because I prescribe Suboxone. I'm happy to see you in my office and I'll take care of you. But I think that there's a lot of shame, a lot of stigma, and sometimes people are kind of coming to that on their own and getting it, illicitly or from the streets. And so that's something to know about. So I have this big qualifier and then I have it all crossed out, right? Because at this point, we should be talking to just about everybody about Narcan. Every patient who's on prescription opioids, who has an opioid use disorder, including those on medication-assisted treatment, or who have a loved one who uses opioids. And if that loved one or if that patient has ever had an overdose, most likely fentanyl was involved. And in these days, fentanyl is in everything that is obtained illicitly, pretty much. It's really challenging to find something that doesn't have fentanyl, which incredibly increases the risk of overdose. And so even thinking about giving high dose naloxone, I think is reasonable. This is the nasal spray in 4 milligrams. That's the standard dose. The VA is starting to give out 8 milligram for our patients who are at a special risk. And so that's something that you should probably be thinking about. And I think, we're not giving enough of this out. And I think we need to be prescribing more and more of it. And I know I have a number of people who just prefer to carry it, they're just out and about town, and you never know when you're going to encounter, a life-threatening situation like this. So I think that it's important that more people have access. So talking about cannabis use. So I'd be remiss if I didn't talk about cannabis use in this presentation. So older adults are using cannabis in greater numbers, and I found a statistic that those who are 65 plus are actually the fastest growing group of cannabis users. Now, when we're talking about cannabis, we're talking about all cannabinoids, all cannabis products. And so that's not just THC, which is the psychoactive component, but also cannabidiol. Also, we're talking about, different forms of cannabis. So cannabidiol is a product that is available now legally over the counter, not regulated. However, many of those products do contain THC. It's really critical, if somebody's going to be using cannabidiol, because there is some evidence that it can be helpful for pain. There's some evidence that it can be helpful for anxiety. There was even a study looking at it in PTSD. Of course, these are studies in younger folks, right? But these products aren't regulated, and so many do contain THC, and so that's something for people to be aware of. Another thing to know about is that older adults may be more susceptible to side effects. I have a number of older adults in my practice who, used throughout their younger years without issue, and then they became older, their brain became more vulnerable for whatever reason, and now it just causes a lot of cognitive problems. It doesn't do it for everyone, but certainly I have, a good handful of people in my practice who are inappropriately using cannabis, or it's having untoward effects cognitively, making them really tired all the time. I had one patient who has dementia, lives with his son, and the grandson kept bringing in cannabis for grandpa, and he'd just go on a total loop, get really delirious, be like rolling around on the floor, and his son would have to call 911. Finally, the son was able to work it out where nobody is bringing cannabis into the house, but that was after a prolonged delirium, and that actually necessitated a rehab stay in short-term rehab because he had become so deconditioned in the hospital. So that was really a shame, but thankfully that patient is doing much better now. Lung issues, that's something to be thinking about. I have a number of patients with COPD who still want to smoke cannabis, and I really encourage thinking about other routes of administration. I mean, it's all about harm reduction. If somebody's really not interested in sobriety, then that's where my focus goes, is to harm reduction. And so that's something to be thinking about if somebody's having, a lot of lung problems, or if somebody has COPD or another lung pulmonary diagnosis, may want to be thinking about encouraging other routes of administration. So substance use can be associated with cognitive impairment and can be a risk factor for the development of a neurocognitive disorder. So let's talk more about that. So cognitive deficits are usually associated with withdrawal or intoxication, and they're often temporary, but advancing age increases the vulnerability to the negative cognitive effects of substance use. So there's kind of four camps here, right? And I mean, this is no surprise to anyone, but so the cognitive effects of chronic use might resolve really quickly with sobriety. They might resolve after weeks or months of abstinence. They may only resolve with extended abstinence, talking 6 months or more, or they may not resolve at all. The effects may be permanent. It's tough to know, but that's kind of the way that things may go. So the impact that substance use has on the brain does depend upon a number of factors, the length of time that a person has been using the substance, how frequently they've been using, the typical amount that they've used, and the route of administration. But just in general, the longer and heavier the use, the more likely it is that substance will have negative effects on the brain. And cognitive effects can make it more difficult for patients to engage in and benefit from healthcare and other services. And the effects on executive function, if that's an issue, they may make patients vulnerable to relapse during early recovery. So just kind of the cognitive effects of substance use plus other cognitive disorders combined with substance use, all these things kind of combine to create havoc and really, cause problems. So in terms of alcohol use disorder and cognitive impairment, this is the most common reason why I get consulted and in somebody with a substance use disorder. Alcohol use disorder is of course associated with alcohol-related dementias, as proposed by Dr. Oslin. There's kind of a criteria out there for what constitutes an alcohol-related dementia. And I have a slide a little bit further on that shows the prevalence of alcohol-related dementia related to other etiologies in different age groups. But alcohol also increases the risk of Alzheimer's and vascular dementia. So common things being common, most of the time when I'm getting consulted, it's not in fact an alcohol-related dementia, but alcohol has certainly played a role. And the good news, if it is an alcohol-related dementia, or if it's a mixed etiology and there's some component of that, that can actually show some improvement with sustained sobriety. And harm reduction can be really helpful too. That's not necessarily in the data, but if we have somebody who's able to achieve sustained sobriety, they are able to have some meaningful improvements on neuropsychological testing and also on quality of life, as measured, in various studies. So I feel like that's really important. So high alcohol use increases the risk of dementia and does result in smaller hippocampal volume. So you see this slide here, and so you see the hazard ratio increasing here, and the number of units per week increasing, and 10 units is 5 12-ounce beers. So you get above 5, and then you start to take off in terms of a hazard ratio. And this is fascinating here. That's kind of interesting. But so you see that there's this kind of linear relationship here in terms of risk of diminished hippocampal volume and alcohol units per week. So here's that slide I was talking about with the types of dementia. So we have late onset on the left-hand side. So you see alcohol-related kind of falls into the other category, number 6. But then when we're looking at early onset, it's actually kind of number 4 in terms of being most common, even above Lewy body and other things like multiple sclerosis, which of course is relatively common, unfortunately. So, relatively talking about neurologic disorders. So alcohol-related dementia is much more commonly a cause of early onset dementia. Did want to talk about benzodiazepines. We'll kind of go through different substances. So benzodiazepines and cognitive impairment. So intoxication and withdrawal can lead to confusion and disorientation. Of course, benzodiazepine withdrawal can be life-threatening, following the similar pattern of alcohol withdrawal in terms of risk for seizures. Longer-acting benzodiazepines are more commonly associated with acute cognitive impairment from the substance. But benzodiazepine use is also associated with an increased risk of Alzheimer's disease, and the risk was increased by 43 to 51% amongst those who had used benzodiazepines in the past at all. And the association was stronger for long-acting benzodiazepines. Then there was this recent, population-based, registry study out of Europe that showed a really strong correlation between any benzodiazepine use and the development of a dementia, specifically Alzheimer's disease later in life. And that association was significantly stronger and increased depending upon the dose. So it increased linearly with the dose, it increased linearly with the cumulative dose, it increased linearly with long-acting versus short-acting in terms of secondary metabolites and that sort of thing. And so, of course, there's not been a randomized control trial, and there won't be. We can't establish causation, but the correlations are quite impressive with benzodiazepines and dementia, and that's kind of what I'm sharing with my patients. Talking about cocaine and other stimulants. So definitely, when you think about cocaine use and other stimulant use, you think about all the vascular risks that are associated with that. And certainly, the risk of having strokes. Cocaine is associated with several mechanisms of brain injury, so not just vascular, but other mechanisms as well. And there's this phenomenon called cocaine-induced leukoencephalopathy that unfortunately can happen from prolonged use. So studies have clearly demonstrated, cognitive impairment associated with cocaine use. So talking about cannabis, so we know that intoxication slows reaction time, impairs attention and coordination, and also impairs motor coordination, leading to increased risk of falls and things like that, which, oh my goodness, playing that out, it's like could have a fracture and then, succumb to that, could have a brain bleed and succumb to that, or have sequelae from that. Withdrawal is also a phenomenon that happens with cannabis. People are a little more irritable, a little more angry, may struggle with anxiety and depression, may struggle with disturbed sleep. I have a number of folks who use cannabis to help themselves get to sleep at night. And so you can imagine that stopping the substance, what might lead to trouble with sleep. Long-term cannabis use has been associated with impaired learning and retention and retrieval of dictated words. However, it's not clear how long those deficits persist, right? There hasn't to date really been a study that's shown kind of long-term cognitive impairment, even if somebody stops the cannabis. So cannabis is linked to dementia is not known at this point. It hasn't been studied enough. We don't know. When I generally have patients who are using a lot of cannabis and having cognitive sequelae from that, I can think of one patient in particular, when they don't use, they're much clearer. They look much different. So it seems like it's far more acute and more of an acute issue. However, one study looking at cannabis use in older adults did find lower perfusion to the hippocampus. So that's something good to know, but still in theoretical territory. Talking about opioid use and cognitive impairment, so we know that in terms of intoxication, we kind of know what that looks like. So I did just want to say, just throw out a pearl about opioid withdrawal in older adults. So generally, I think as a society, we're pretty tough on people who are going through opioid withdrawal. It's a resource utilization issue. We don't have enough beds to admit people with opioid withdrawal. It's generally thought to be non-life threatening, and we just give supportive care. But I want you to rethink that for older adults. Older adults are potentially extra susceptible to electrolyte abnormalities from the fluid loss. They may be susceptible to deconditioning from being down for a prolonged period of time, like not being able to be as active. They're at risk for arrhythmia from the electrolyte abnormalities that can happen with fluid loss and fluid shifts, with the diarrhea and the vomiting and all the sweating and lacrimation and all those things. And so I would encourage you to rethink that and really think about that an older adult may in fact need to be admitted for opioid withdrawal. We're different at the VA in that we do admit for opioid withdrawal. That's generally our policy for all ages, but especially for older adults, we do. But I do understand, that there are limitations on the system, and that generally for something that's not thought to be life-threatening, that it may not be indicated. But I think for older adults, I just encourage you to rethink that. We know that chronic opioid exposure is linked with neurocognitive impairments. There was one meta-analysis that showed dysfunction in impulsivity, so in cognitive flexibility and verbal working memory. And long-term opioid use may contribute to cognitive decline, but that's not fully clear at this point yet. That's still kind of under investigation. So I did want to talk about neuropsychological testing in substance use disorders. I'm sure that, that hearing about kind of the general workup of cognitive impairment and, thinking about getting neuropsychological testing. Well, I think there's some folks who say, oh, this person has a substance use disorder. No, no neuropsychological testing until they're sober for, 6 months or a year. And that's just not always feasible. So it can be very helpful. I definitely have cases where I'm like, is this related to their substance use, or do they have an underlying Alzheimer's disease? Do they have an underlying vascular dementia, or is something else going on? I've had situations where it's like, are they just, acting a fool because of their substance use disorder, or like, is this frontotemporal dementia? And so the neuropsychological testing, of course, if they can participate, if they have the faculties to participate, can really be helpful in terms of showing us domain by domain, what is the pattern? And I think that that can be incredibly helpful in pointing to an etiology. And so while usually we try to optimize risks as much as we can, like substance use, before engaging in testing. So we may say, for example, I work on a team called Virtual Geriatrics at the VA, and we provide geriatrics consultation to rural older adults within the VA system. And we oftentimes will say, because we kind of have several options of the types of visits we offer, and we can offer a team visit with a geriatrician or with myself, or we can offer neuropsychological testing with our neuropsychologist. And so we may say, we may get a consult for neuropsychological testing for someone with a substance use disorder. And we may say, okay, we're going to have them meet with, me, the geriatric psychiatrist first, and kind of ascertain kind of what wiggle room there is and how interested they are in engaging in treatment. And sometimes I have had cases where, we get the neuropsychological testing and we can say, hey, no, this is really due to your alcohol use, or no, this is really due to your cannabis use. And that can be really helpful for people to hear. And I think, I have had situations where that's led people to engage better in treatment. So I just want to encourage, I do understand that neuropsychological testing is a limited resource. So we have to think about how we're using it. But there may be some cases where somebody is still using a substance or abusing a substance, and we may want to consider testing. So the recommendation for screening is to screen all adults age 60 plus for substance misuse annually and when life changes occur. So talking about an invisible population. So we know older adults are less likely to self-report a problem and less likely to ask for treatment than younger adults. And we also know that providers' beliefs and attitudes towards older adults can lead them not to screen for substance misuse. These ideas like they're never going to change. I don't want to be disrespectful. Oh, it's not causing them any issues. Oh gosh, it is at his age, it's normal to forget things, or even, oh gosh, he's in his 80s. He probably doesn't have that much longer to live. We should just let him enjoy his alcohol, but it's like, we really need to get people into treatment, because we know that while older adults are less likely to be screened, identified, and referred for treatment, they are just as likely, if not more likely, to benefit from treatment. There actually have been some studies looking at psychosocial treatments for substance use disorders, and they have shown that older adults are actually more likely to achieve sustained sobriety at a year or 2 years compared to their younger age cohort. So that's really cool. There can be a lot of barriers to care for older adults. So stigma can be really high. Most treatment programs are not tailored to older adults. So they may be in with a bunch of younger folks and may not really feel like they fit into the treatment program. Sensory impairment. So are we accounting for hearing loss? Are we offering like pocket talkers, or are we, encouraging people, if they're able? At the VA, we have audiology readily available, but in the community, that may not be a covered service under their insurance. Transportation can absolutely be an issue, especially if somebody has lost their driver's license, due to DUI or cognitive impairments. And then mobility and other medical issues can make it challenging to get, even, getting from the parking lot into the program. That may be something that's not thought of at the substance use treatment center. And then financial concerns on a fixed income. There's barriers to access and barriers to afford care, which we'll talk about on the next slide. So, Medicare is not subject to federal parity law. However, as of 2020, comprehensive addictions treatment is covered. However, Medicare Advantage plans, which are becoming more and more popular, have varying coverage, and studies have shown deliberate decreased reimbursement and restriction of provider pools in Medicare Advantage plans, which lead to people not being able to access treatment. And then in terms of Medicaid, it varies state to state. Wisconsin Medicaid does explicitly cover addictions treatment. Many local programs in the Madison area, I understand y'all are coming from all over the state, but many local programs in the Madison area do take Medicaid, but many don't take Medicare. So that can be something that's really challenging for folks to work around. So treating substance use disorders in older adults, there's really not a lot of data out there. There's definitely more on psychosocial treatment, but not so much on pharmacologic treatment, which of course is where I come in the most. So we currently only have 2 randomized controlled trials evaluating pharmacologic treatment of substance use disorders for older adults. The first was 1997, naltrexone versus placebo for adults 50 to 70 with alcohol use disorder, and then 2005, naltrexone versus placebo. And this was actually a study looking at alcohol use disorder and depression. And they used naltrexone as an adjunct for sertraline. However, they did measure sustained sobriety at, like at 2 months, 6 months, and a year. I don't remember the exact data, the exact time points, but they did measure that as a secondary outcome. So both were positive, favoring naltrexone. However, these were small sample sizes, mostly men. I believe they were both conducted within the Veterans Health System. So we really don't have much. This 1992 randomized control trial is really cool. So I share it here because I think it drives home a point. So they had a residential rehabilitation program. They had 2 programs, and one was adapted to treating older adults, and then one was not. And the older adult program was more successful than the standard program for older adults. And it's fascinating. This is another study that shows that folks did better with age. So abstinence rates actually increased with age. So every 10 years, folks were 2.5 times more likely to report abstinence at 12 months. So when they broke it down, 60 to 70 compared to 70 to 80, compared to 80 to 90, compared to 90 to 100, folks were 2.5 times more likely per decade to report abstinence at 12 months, which is pretty cool. So the bottom line is we really need to tailor our treatments to older adult populations and really meet people where they're at. And I just think that that's critically important, and the data really shows that. So talking about pharmacologic treatment in older adults, so FDA approved medications for alcohol use disorder have not been studied adequately in older adults, but we know that naltrexone definitely should be considered. It probably has the strongest data out there for alcohol use disorder in general. It's a great medication for people who can take it, but certainly if somebody is taking long-term opioids, if somebody is going to require long-term opioids, we want to be really careful, right? We don't want to be blocking opioid receptors if we're trying to treat somebody's pain via that mechanism. Acamprosate's another great medication, but it's a 3-time-a-day pill. Naltrexone, I should have said, is available once-a-day pill or in once-monthly injection. Acamprosate's a 3-time-a-day pill. It can be very helpful. It's been studied mostly in folks who are sober initially for like 2 weeks or more, which makes it, a little tough to extrapolate to somebody who's more newly sober, somebody who might be going through withdrawal and detox and then, starting the med right away. But it's good. I've found that it's a little limited in that I've had a number of people get pretty sedated on it, but it's a good medication. Naltrexone, of course, you have to be concerned about liver enzymes and hepatic damage. So you have to be monitoring liver enzymes prior to initiation and make sure that they're not too elevated. They can be a bit elevated and still start. And then you want to monitor, typically I will check within, a couple of weeks to a month just to make sure that there hasn't been an elevation. And then you generally don't need to check again. Acamprosate there is renal dosing with acamprosate. So if somebody has CKD at stage 3 or more, then you want to renally dose the acamprosate. Disulfiram, that's antabuse, the medication that makes people sick if they drink alcohol. I tend to avoid that in older adults. There's a lot of drug-drug interactions, and the alcohol-related reaction can be life-threatening. And older adults are more susceptible to that, of course. And so I tend not to use disulfiram. Where I do use it is if somebody has a social contract. So if somebody has a loved one, a boss, a landlord, somebody that they're connected to, and they make this contract and they're like, I'm not going to drink because I value our relationship, then they can, have like monitored taking daily of the medication. So it's like, okay, it's the morning, I'm going to take this medication, I'm committing to you, I'm not going to drink today. And that's where I've seen it be more helpful. Then topiramate, it's funny that a drug that's nicknamed Dopamax would be useful in older adults, but I see folks who are more treatment refractory. And so I have used a fair amount of topiramate in older adults. There are cautions, of course, it can cause cognitive problems. Cognitive dulling can cause that specific like word finding difficulty, and can also precipitate renal stones, kidney stones. So something to think about with topiramate, but it's a great medication. And the data is actually quite robust in terms of its effectiveness. Of course, it hasn't been adequately studied in older adults, but in like mixed populations, it has been. And then gabapentin. Gabapentin is especially helpful in early sobriety, can really dampen down that hyperactive nervous system that can lead to so much anxiety and insomnia in those early days and months of sobriety. And then consider baclofen. So there's been some study of baclofen, and in general, folks tend to recommend it for those who have significant muscle tension and anxiety as a precipitant to drinking. You're like, oh, I just get so tense and I need to relax. And baclofen can be helpful in those cases, but it's not studied as well as the other medications.
Just a warning for a 5-minute notice. Dr.
Oh,
Radue.
thank you. Gosh, I'm sorry. I will speed through here. So this is talking about opioid use disorder. So older adults should be screened for opioid use disorder. The threshold to admit for opioid withdrawal management should be lower than that for a younger adult. Opioid withdrawal can be life-threatening in older adults, like we talked about. And then with withdrawal management, opioid agonist treatment is preferable to non-opioid treatment. And this comes out of Canada, but it's impressive that they have these guidelines for treating older adults, and they're evidence-based. So first line, they recommend buprenorphine naloxone maintenance. So that's Suboxone. Buprenorphine is preferred over methadone for pain control and medication-assisted treatment. In older adults, it's generally less sedating, less of a fall risk, less respiratory depression. The metabolism is more stable with aging, less cardiac risk. And second line, they say methadone if buprenorphine is not tolerated. If opioid agonist treatment is contraindicated, you can offer naltrexone. But naltrexone for opioid use disorder is really tough because you have to be off of opioids for a week. And we know that that's really challenging. And they say go slow, use the lowest dose, and monitor closely. So I'm going to go through some cases. I hope I can get through all of them. I sincerely apologize for taking so much time on my earlier slides. I was able to get through them all when I was practicing, but I guess I'm a little more verbose today. So these are the most common reasons why my team gets consulted. So does this patient with a substance use disorder have a neurocognitive disorder? I'm not going to focus on capacity today, but the other question, how can we manage behavioral disturbance in this person with dementia and a substance use disorder? So does this patient have a neurocognitive disorder? So this is Mr. Y. He's a 73-year-old widow and he lives alone. He has a long-standing history of alcohol use disorder. And the primary care doc gets a call from his daughter who lives out of state, and she's concerned. He just seems more forgetful. He agrees to come in and he scores a 26 out of 30 on the slums, and he's drinking 6 to 8 beers a night. He says, I do not want treatment for my alcohol, but he did agree to see the geriatrics consultation team that I work with that I referenced earlier. So we meet as a team, we triage. There's no abnormalities on his labs with the exception of an elevated MCV, mean corpuscular volume, which can happen with prolonged alcohol use. It's reasonable to proceed with neuropsychological testing. We actually decide to just jump right to that. The social worker completes a psychosocial assessment, and the declines have been gradual over the last 1 to 2 years per his daughter's report. The neuropsychological testing shows major amnestic and executive function deficits. There's a clear functional decline. He's getting lost while driving. He's mismanaging his meds. And so we diagnose him with a major neurocognitive disorder. So then we get together and we review the testing. We talk about how we would consider further testing and imaging. We want to determine if there's possibly vascular component to this. We utilize motivational interviewing techniques. The amnestic deficits might be responsive, and even the executive function to sobriety. So this substance use disorders treatment is available at his clinic. So we offer connection if he's agreeable. So then I met with them. And we reviewed the diagnosis. He actually agreed to an intake with the substance use disorders treatment program. And I discussed options with him for medication assisted treatment, and he actually opted to try naltrexone. So then managing behavioral disturbance, I'm just looking at the time. So Mrs. G is an 83-year-old veteran who lives with her husband in rural Illinois. They moved to be closer to their daughter. She has a very low slum score. She's actually already activated previously in another state, and her husband is the first agent. And so he reveals that she can get angry in the evenings, especially after she's had a few. She'll oftentimes refuse her nighttime medications and say that he's poisoning her. He admits that he's the one buying her alcohol since she can't coordinate getting out anymore. And she's drinking at least 1 bottle of wine per night. So we met and we decided that I would meet with them. And so I performed an NPIQ, which is a great tool for assessing the full scope of behavioral and psychological symptoms of dementia. We talked about the best option for detox, and this is a situation where they did not want her to come into the hospital. They really felt like that would be detrimental. We talked about a slow, gradually like replacing her wine with non-alcoholic wine. That sometimes works, sometimes doesn't work. We talked about really close follow-up, checking in daily or every other day, with my nurse. We talked about behavioral strategies and pharmacologic treatment for BPSD. And then this is my last case. So this is an 81-year-old veteran who I saw. He has severe COPD and rheumatoid arthritis with significant chronic pain. He lives in rural Illinois and he smokes cannabis multiple times a day. And his neuropsychological testing showed severe deficits in attention, but no other deficits. And so I talked with him about CBD only preparations in terms of harm reduction. And we reviewed some options that there may be some evidence that may be less cognitively impairing. So there we go. Questions? We have a few minutes.
Thank you so much, Dr. Radue. That was super helpful. Again, I think a lot of us are facing more and more of patients who are, just like you're mentioning, who are struggling with these changes with the opioid epidemic, with cannabis being more accessible, with alcohol-related misuse in the context of COVID. So we really appreciate your going through that. So I know there is one question in the Q&A, and if others have questions, please feel free to add them into the Q&A. And even if we don't have time to get through them verbally, we can put some responses. And if Dr. Radue is willing to answer those typed as well. So Dr. Radue, there's a question from Raleigh Forge. I'm probably mispronouncing your name. Sorry about that. I'm a resident. I haven't had to prescribe naloxone yet. Does insurance cover this, or how much does it cost?
Yeah, that's a great question. So there's a lot of grant programs out there that will simply cover it if you go in to get it. I will say that there have been some situations where people have been discriminated against for carrying naloxone or obtaining a naloxone prescription when they're not using it themselves, but it's rather to have for safety reasons for other people. So generally at the VA, it's fully covered. In the community, there's a lot of programs where you can obtain it for free. For example, if you go to community pharmacy, they have it available readily. And I know a lot of other pharmacies have it available readily as well. And then I know I work with the Medic Free Clinic system out of the UW, and they are just kind of giving it away to folks. They have a grant that allowed them to purchase some of it. So hopefully that's helpful. I apologize, I don't have more information on the community, but that's what I know.
And then Dr. Joelle Milligan from Rhinelander has a question. Is there any long-term data available for cognitive testing for patients with alcohol use disorder or cannabis?
Yeah, so I think I am wondering if you're wondering like long-term data on kind of how cognitive testing might look over time with alcohol use disorder or cannabis, or long-term data. Okay, how it might look over time. Yeah. So I think going back to those slides for alcohol use disorder, we know that over time that people are, and you're right, I did my slide that I showed was hippocampal volume. I didn't talk about neuropsychological testing, but I do have some slides from other presentations that show that yes, neuropsychological testing tends to decline over time with chronic alcohol use. For cannabis, we don't have that data yet, unfortunately. But with alcohol use disorder, we do, and that the deficits tend to be predominantly in executive function and also amnestic, so memory.
All right, I think we're out of time, but if you have other questions for Dr. Radue, feel free to put them in the Q&A and she can watch for those and respond in the Q&A section. But thank you so much, Dr. Radue. We really appreciate your thorough, thoughtful presentation and how we can help partner with our patients to work through these substance use disorders and improve quality of life. So thank you. And now we're going to move on to our third presenter, and I want to apologize. It was our fault that we messed up the order. So I apologize to Dr. Bukowy. I hope I pronounced it correctly. So Dr. Radue, if you want to, let's see, stop sharing your screen. Let's see. Yes, okay. So, so we'd like to welcome Dr. Elizabeth Bukowy. Let's see. Do you have access to share your screen?
Yes, let me do that.
Right. So Dr. Bukowy is a colleague from the Medical College of Wisconsin. She is a division, she's in the division of geriatrics and has received training in both internal medicine and geriatrics, and did a combined fellowship program, and also did training in palliative care at MCW. She has her medical degree from Midwestern University in Downers Grove, Illinois, and her undergraduate degree from Marquette University in Milwaukee. So a lot of great Midwestern training. She's medical director of the Lutheran Home and Congregational Home, and also practices at the Clement J. Zablocki VA Medical Center in Milwaukee. So another clinician who takes care of veterans. So she enjoys teaching residents, students, advanced practice providers, and nursing staff about a variety of topics that apply to nursing home care and older adults. And so one of her passions is advanced care planning, dementia education, and end-of-life care. So again, this is an extremely important area as we think about goals of care for our patients with dementia and their families, engaging caregivers and patients in setting up those goals. So we're so thankful to have, and you'll have to correct me if I said it wrong, but Dr. Bukowy here to present to us today. So welcome.
Oh, thank you so much. Yeah, so I can't even add anything to that wonderful introduction. Thank you. So we're going to talk about we're going to get into it, do some difficult conversations around palliative care. And I practiced this talk with a bunch of my colleagues, and it probably was going to be like 3 hours long. So I really tried to hone it in and narrow it to really give you guys a good, big picture outline. Hopefully you get some tidbits throughout the way. And if I say anything on here that you want more information on, you're welcome to reach out to me. I might reference some documents that I've used for my educational pieces for my nursing facility. So I'm happy to share any of that information with you guys. So, but we will get started. So I have no disclosures. I just want to make sure you guys can see everything okay, correct?
Yes, and your only disclosure is a cute baby that probably makes you sleep
Yes.
deprived.
Yep, that's little Shelby. She's bigger now. I should update that picture. So again, conclusions are going to be, or at the conclusion of this, I want you guys to be comfortable with determining differences in palliative care and hospice care, providing anticipatory guidance on the dying trajectory, and being able to educate not only patients and families, but also staff members. Work on conversation tools for advanced care planning, initiate code status discussions, and also just in general be better feeling, better confidence for educating families and communicating with staff. So to start, palliative care should be considered a philosophy of care. And when you're describing it to people, it should be about specializing in people with lifelong illness. And we focus on symptom management. A lot of times that symptom management is refractory cancer pain or end of life pain or shortness of breath. So any type of symptoms that go along throughout, beginning, middle, and during the dying process. Palliative care also helps with a lot of those difficult treatment decisions. So when we say goals of care, a lot of times our families don't know what goals of care mean. So if we just we go into the conversation and say, we're going to talk about some difficult treatment decisions that you guys have been considering with your medical team. And that's kind of a good checkpoint too, because family members will bring up like, oh yeah, I know mom's dementia is getting worse and we're having a harder time swallowing. So it's kind of a good tester and opening line. So we also, palliative care as that philosophy provides support for patients and the families. It's rooted in the hospice movement. However, it's not necessarily for those with a life expectancy of less than 6 months. I tell people that it's appropriate for any age and stage of any illness, and it can be in addition to potentially curative treatments. So I remember getting this on my first palliative care rotation as a medical student 3rd year, and it's just kind of stuck with me. So to start with, you can talk about this, palliative care, hospice, bereavement trajectory with any lifelong or life-limiting illness. I'll talk about it with, oncologists. I'll talk about it with cardiologists and things like that. For this talk, I'm just going to reference it as in terms of dementia and progression. So we may see that at the beginning of the diagnosis of dementia, while we don't have curative treatment options for dementia, we do have things to try to limit the burden on our patients and loved ones who are taking care of them. So in the beginning, we may be just talking about potential appointments with neurology or geriatrics or things like that. We may be talking about the advanced care planning piece, about goals of care, about code status, things like that. Maybe a little bit further along this line, we may be talking about medications to try to slow the progression or a more supportive living environment. You can see that as time goes on, our modifying therapy for something like dementia limits itself, because once we have a chronic illness, we know we have it, we're always going to have it, and it's going to get worse. So palliative care can become a much bigger part of these patients and family members' lives. And in here, it might be, as things progress, it might be more of a discussion about, we're losing weight despite doing oral feeds, or we're getting more infections, or we're going to the hospital more and more, and mom's just not bouncing back the way she once was. Then you can see that there's this line of, once somebody reaches a life expectancy of less than 6 months, palliative care can kind of flow into hospice care, but it is a choice for family members and our patients to decide if they want to sign on to that benefit. And I'll talk about that in a later slide. And then you can see that then we go into bereavement, which is a hospice agency usually provides 13 months of additional bereavement support to kind of get through all those firsts of, the first birthday, the first anniversary of somebody's death. So something that can help you, and what I teach my residents and nurse practitioners and things like that, to try to figure out where somebody is at in their, their trajectory is, would you be surprised if this patient died in 12 months? And it helps identify those with, a 1-year mortality risk. That's the goal of it. We're pretty good as clinicians, social workers, nurses, looking at somebody and saying, yeah, I think this person has over a year. I would be very surprised if they died within the next year. We're not as good at picking out those people that maybe have less than a year. Maybe we're seeing just the beginning of their, slow decline. So if you do, this surprise question is really helpful for those people that you're able to pick out and say, oh yeah, I think we're in the beginning of somebody's decline. And this is kind of like your trigger to say, I think there's some unmet palliative care needs. Maybe we need to have treatment decision discussions. Maybe we need to have advanced care planning. So it's just a nice checkpoint. So when I'm talking to my learners, I'll say, this person is not dying today or tomorrow, but this person is probably going to be dying in the next year. So it just kind of alerts them, and it's a good kind of warning shot for patients and the families. So when I initially did this talk, I think I talked about hospice for like 15 minutes. So I limited down to like 1 or 2 slides because so many of you are already aware of hospice and can get more information on hospice from, a specific hospice rep. But in general, when I think about hospice, I think of it in the Medicare hospice benefit. We find that those people that do not have Medicare or, even Medicaid, that the hospice benefit isn't quite the same. And we really need to have support of our social workers and case managers to determine what the hospice benefit is. So I'm just talking about Medicare. And in general, for all of us to know, usually it covers 100% of the hospice care. So that would be the medical equipment, nursing, counseling, bereavement. It provides, you can get a very small copay, but it's rarely ever instated. And it should be providing 4 levels of care pending the symptom burden. To be eligible for hospice, it would be somebody that's entitled to Medicare Part A. So that's the piece about, signing on to hospice. So you're basically saying that you are, deciding to sign on to hospice. So your Medicare Part A will now pay for your hospice benefit. And now you will no longer, be going back and forth to the hospital because you chose this different plan of care. So that's the piece. You're signing on to an agreement, a benefit plan. 2 physicians need to agree that there's a life expectancy of less than 6 months if somebody's disease runs its natural course. And it's just interesting to note that DNR is actually not a requirement for admission. A lot of people think that, but actually it is not uncommon to sometimes have people on home hospice that may be full code when they first are admitted, and then shortly they do transition to a do not resuscitate. And I think I took out, in general, I'll just talk about the 4 levels of care that I had referenced on this slide. And you guys can always reach out to me or talk with a local hospice rep. But in general, the 4 levels of care that a hospice must provide is going to be your traditional home hospice. And that is wherever our loved ones call home. So home can be at somebody's actual home, an apartment, a condo, a nursing facility. And that's really that routine level of care where people don't have a significant symptom burden. And, they can be cared for by family members at home, doing the majority of that 24/7 care, or if they're in a facility, then the staff provides that more 24/7 care. They also would be an additional level of care for hospice of an inpatient level of hospice care. And that's for those people that are dying not only quickly, but symptomatically. And they need just focused hospice staff taking care of them. They also provide respite care with hospice. So that's your 3rd level of care. So that means that if you're taking care of your loved one at home and you have to go to a wedding, well, you call hospice and they work on making sure that your loved one has care for the time that you're going to be gone. And then they also provide continuous care, which basically is if somebody is having a change, whether, if they're at home or at a facility, something like that, and their symptoms are out of control despite, staff or family managing it, then the hospice agency has the ability to send somebody out and really help control those symptoms and make a plan moving forward for if the person is going to stay where they're at or if they need, let's say, an inpatient level of hospice care. So the average length of stay for hospice is going to be 89.6 days. So that's the average. The median, or the one that happens kind of in the middle, if you're looking at a graph, is going to be 18 days. So that should really tell us that, wow, there's a lot of people that are spending less time on hospice. And it's been studied that the most benefit from hospice services are for those people that have been enrolled in hospice for at least 80 to 90 days. And that's because these people are able to get to know their caregivers, get their symptoms under control, get whatever emotional or psychological stress that goes along with hospice under control, and really improve that quality of life and make sure that whatever time they have remaining is good quality time doing the things that they want to. And that doesn't happen immediately. That doesn't happen in a week. So that's why we look at 80 to 90 days as getting the most quality of life from a hospice benefit. However, less than 50% of people are enrolled for 30 days, and only 30% of people receive care for 1 week. So we really refer people too late to hospice care. So just a thinking question as we move on, how do you educate families, staff, or patients on dying trajectories? And do you provide anticipatory guidance when somebody is entering these stages and what you expect to see as a normal part of the dying process? So this is a great set of charts that I actually do reference and will draw out to families depending on where their loved one is. So most people say that they want to have a sudden death. They want to live their life to the fullest and then have one day where they go to sleep and never wake up. Unfortunately, that's rather rare. Some people may have a terminal illness, such as this is like a cancer trajectory where somebody is diagnosed with a cancer. Maybe they have their cancer is under control for a period of time, and then unfortunately, treatment strategies are no longer working and they have a rapid decline. And then you get down here to the bottom, so organ failure and frailty. So I kind of look at these two as my dementia dying trajectory. So because you can think of dementia as somebody that's having brain failure. So you may talk with family members about, repeated hospitalizations and repeated episodes of delirium where their loved one does improve a little bit with maybe a little bit of hospitalization or antibiotics or IV fluids. However, they never quite get back to their prior baseline. And so you just have these periods of worsening due to an acute illness, and then slowly but surely you just see kind of the downward trajectory. And you never, commonly family members will say, well, my loved one has been here before, they got antibiotics, they got IV fluids, and they survived. And I think it's important to draw out something like this to tell them that we never know when the decline is going to lead to somebody's death. And you can also kind of see frailty. So you have those people that just slowly dwindle, people that have, very low function, and over a very, usually it's a longer period of time with somebody with dementia that they just kind of slowly but surely decline. And it can sometimes be a really slow, painful thing to watch for family members. So sometimes drawing out these different graphs could be helpful for them to kind of see where their loved one may be at on their dying trajectory. So anticipatory guidance on the stages of dying. This is something that, all patients and family members need to feel that they're not being abandoned. And sometimes talking to them about the different stages of dying is a way to kind of give them a roadmap, because a lot of people have never heard the roadmap of how somebody dies. So we always want to provide active listening during this time because it's a very emotional, stressful, tense time for these family members and patients. Offer to provide this anticipatory guidance about the expected changes, both in their loved one's cognition and what their physical exam could be. And then always ask them if they're interested in prognosis. I've only had 2 cases where somebody told me no, that they didn't want to know, and that they said once they knew that they were nearing death, that was enough for them. But in most cases, people want to know. They want to plan. They want to kind of have an idea of gathering other loved ones, things like that. If you do give a prognosis, I always do ranges, because otherwise you're going to have those people that mark down, oh, the doctor said in 10 days, my mom was going to die. And if that goes 11 days, then they will never believe people again about it. So I always do ranges. So I talk about hours to days, days to short weeks, things like that. So we look at anticipatory guidance, these stages. So the early stage is going to be your long days to short weeks. And that's somebody who may now be bedbound, may not be taking much or if any by mouth medications, food, liquid, things like that. You may see these people have cognitive changes more so than their usual dementia. So just kind of these beginning stages where you're just like, things are changing for this person. There's a middle stage, which again, middle stages are always hard because you never quite know you're in the middle until you're usually in the end. But it's just kind of a more sleepy, worsening mental status kind of stage. The late stage is probably the one that's been the most studied and most looked at. So that's going to be your hours to short days. We're usually pretty good at figuring that out. Most of us can look at somebody and say, I think this person is very short time. I think they have hours. I think they have short days. So we're usually pretty good at that. So that's looking at somebody and they have, pooled oral secretions. They have that loss of swallow reflex. That's when you may hear the death rattle. And I'll talk about that in the next coming slides. The person may be unresponsive. They may have cold extremities or mottling or a blue hue. They may have changes in their breathing patterns, which I'll also talk about. The most beneficial thing to look at as a provider is going to be somebody's urine output. So once somebody has very limited to no urine output, that is actually a very strong indicator that somebody's time is less than 24 hours. I would never say that to a family member. I wouldn't say your loved one has 24 hours because they have not urinated. But I would say that, at this point, when we're not making much urine, I think time is rather short. I think it's somewhere between the range of hours to short days, so that the family knows that their time is very limited. So we'll talk about some brief. So this is something that, you've all experienced the family member that is sitting over vigil, their loved one, staring at their breathing and looking and counting and things like that. So it's important for family members and loved ones to know that things that you expect. So a normal breathing pattern for somebody in the dying process, no matter what they're dying from, dementia, heart failure, lung disease, can be something called Cayenne-Stokes respiration. And that really is when somebody is having rapid breathing. So you'll see them kind of breathing rapidly, and then they'll have periods of apnea or a lack of breathing. And then they'll start breathing faster, and then it's again another pause. I tell families this is normal. This is not thought to be uncomfortable, and that we look for different things to determine if somebody is uncomfortable with their breathing or not. So it's important that families know this. Otherwise, they're going to worry that every period of lack of breathing or apnea means that their loved one is suffering or suffocating. What I talk to family members about is that things that if they see, I want to know about it because I can help and make their loved one more comfortable, is going to be, and I also say that even with the loved ones that have advanced dementia, we don't need them to tell us that they're uncomfortable, that they're short of breath, that, whatever, that they're in pain, because we can look at the nonverbal cues. And that really helps family members too, to know that we're not just waiting for their loved one who's nonverbal with their dementia to tell us that they're uncomfortable. We look for signs. So we talk about tachypnea or rapid breathing. So somebody that's breathing very rapidly, but they look uncomfortable. So think about running a marathon and you see those people that are using all of their muscles in their in their chest to breathe. They're using their neck muscles. Maybe they're able to tripod or wince or something like that, where they're like leaning over and look uncomfortable. Maybe their nose is flaring. Maybe their brow is has like an angry look or fearful expression on their face, or maybe they're sweating. So they physically look uncomfortable, not just that the breathing pattern is different. So that is helpful for family members too, to know that we look for signs. We don't expect our loved ones to tell us that they're having some discomfort. I always talk to family members about the rally. I think this is very important, because whenever a patient has a rally moment or hour or day, usually family members get concerned that they made the wrong decision and that maybe their loved one shouldn't be on hospice anymore, and maybe they should go to the hospital and get additional treatment. If you educate family members on this before it happens, they're much more accepting of it, and they can actually enjoy that time. So if you just say that sometimes people experience what's called a rally, where they have a surge of energy, they're more interactive, they're more aware of their surroundings, and that can be a normal part of the dying process that some people may or may not experience. And you would just encourage them to use this time meaningfully, interact with their family members, and try to share some memorable time with them. Just briefly on palliative oxygen therapy, there was a study. You can imagine there's not a lot of studies about these types of things, but there was something in the Lancet in 2010 that looked at nasal cannula with oxygen versus a nasal cannula with just regular air, no actual oxygen blowing through it. And they found that there was no symptomatic benefit for people that had refractory dyspnea. And that basically means that people that said, or were able to say, hey, I'm uncomfortable with my breathing, I feel short of breath. If you just put on 2 liters of oxygen, they did not feel better. That the best data we have for those people that are telling us that they're short of breath is actually going to be an opioid medication to help calm the work of breathing. We also find that people that were placed on oxygen, it actually prolonged the dying process. So we always need to have discussions with families about this, and that really there's little reason to go beyond 4 or 6 liters. These are not for those same people that have a sensation of shortness of breath and that they actually have lower oxygen numbers too. So it's those people that feel short of breath, just placing them on oxygen isn't enough. That we should be looking at something like opioids to help with that breathing. However, somebody that feels short of breath and has a lung disease, oxygen may be helpful for them because their lung disease, may be limiting oxygen intake for them. A brief comment on artificial hydration. This is something I think we've all run into, because as mom or dad's dementia is worsening and we're not taking in as much by mouth food or liquids, most people are worried that their loved one is dehydrated. So the only data that's really out there right now is for those with cancer at the end of life, but you can kind of extrapolate it to people that are at end of life. And they looked at people that had 1 liter of fluid versus 100 milliliters of fluid in the IVs, and they had that daily for 7 days. And they actually found that the larger amount of fluid prolonged the dying process by about 6 days, but that was actually no difference in delirium or fatigue. So these people that tried to give somebody IV fluids to try to improve mom or dad's cognition during the dying process, that didn't seem to pan out. And again, they looked at people that had that 100 milliliters of fluid and a placebo in different routes. Again, even if you looked at the fluid versus no fluid, there was no difference in delirium. So again, when I'm educating family members, I will often talk with them and say, look, like, as our body is shutting down, it's not every part of our body is shutting down. And the fluid that we normally would take in by mouth or in an IV isn't going to go in the same places that it once did. And it can cause more discomfort, either by resting in the lungs, resting in the belly, resting in the skin. And that, a small amount of fluid for a couple of days is, we can trial that. I just don't, when you're educating family members, you just want to say that. And if we see that the fluid isn't going where we want it to, or your loved one is in distress because of the fluid, we are not going to continue that anymore. And part of it is you're treating the family members too. And you don't want them to go away with guilt that, man, if we just gave them the tiniest bit of fluid, maybe it would have made a difference in mom's, dying process. So it is that weighing that risk and benefit. One question that comes up is, will morphine kill my mom faster? I've actually had family members directly ask me this question. And I always want you guys to initially respond with emotion, not a medical explanation. Because behind this statement is somebody who's, maybe they're scared, maybe they have guilt or worry, maybe they had a bad experience with hospice in the past or morphine use in the past. So I want, when somebody asks these questions to you, initially respond with emotion, kind of get to and name that emotion. So say, I see you're worried or scared about morphine use in your loved one. And if they don't want the emotional response, if they really want a medical explanation, they'll always ask again. But if you initially respond with emotion, so many times, I would say over 95% of the time, that's really what's unspoken here. Their guilt, their worry, their fear, the realization that their loved one is nearing the end of their life. So that's how I would initially respond. And always confirm and always, report that, your loved one is dying due to their underlying illness, not the opioid. So another few words on opioids at the end of life is patients and families fear them. I had one older adult who, when I started him on a very low dose of morphine, he called all of his family members saying that the doctor started morphine because he knew that the word morphine, or he felt that the word morphine was synonymous with him being near death. You want to make sure people know that the right patient, right dose, right situation is going to be used for their loved one, and that not all opioids work the same on all patients. Opioids are a first-line treatment for somebody that's experiencing air hunger or that feeling of shortness of breath or the physical appearance that somebody is breathing uncomfortable. No opioid is actually better than another. Morphine is just usually the most readily available in most facilities, and it's also the most common. Tolerance does occur. Some people will ask you about it, but that doesn't mean that an opioid should be saved until somebody is really uncomfortable. The efficacy is related to the dose of the medication, not the route. So sometimes family members will just ask you to put an IV and treat their loved one with IV medications. And it's not always necessary as long as we're adjusting the dose for what the person is showing us. And morphine is another good one because it actually comes in a liquid form. And I'll tell people that we don't need your loved one to swallow this. Like, it is a very potent amount and it will be absorbed in the oral mucosa, and your loved one will get benefit from this even without them being able to swallow it. And we also want to be aware that people that have itching or nausea, that these aren't always true allergies, but maybe known side effects. So you really have to dig into whether somebody actually has an allergy to an opioid or if it is a potential known side effect. So our advanced care planning discussions. So, when you look at some advanced care planning, that is the actual discussion and communication with family members and staff. With the purpose to identify a surrogate decision maker or treatment preferences. The advanced directive piece is actually the document that you create either during advanced care planning or at another point. So this was one of the first mnemonics I learned in my first day as an intern in residency. So it's SPAM. So it's really a way for us to feel more comfortable and have a way to ask about a surrogate decision maker, about somebody's preferences for their care, talking about a full code versus a do not resuscitate. And then if you start to have this discussion, if somebody's not ready to make a decision, you say that you're going to put somebody on as a full code or full treatment, and that you're going to ensure that more discussions are going to be held in the future. So this is the way that I actually discuss code status with my patients. And I've created basically this in like a single page handout that I've provided to my facilities that have been very helpful. So if anybody wants more information on it, I'm happy to share. So when I'm talking to somebody about code status, I'll say that I ask everyone this question, even if I think it's unlikely to happen during your stay. And I'll say that we always try to prevent somebody's heart or lungs from stopping. However, if despite our usual medical treatments, such as IV fluids or antibiotics, or even going back and forth to the hospital, if somebody's heart or lungs stop and they are considered to have died, what interventions would you or they want? And I think it's important to make it a conversation and kind of paint that picture for patients and their loved ones so that they know that, you can still do things for somebody even if they are a do not resuscitate. A lot of times people think if they're a do not resuscitate, that means they don't get antibiotics or hospitalizations. So it's important for them to know that, and to also know that we're only talking about when somebody's heart and lungs stop and they are considered to have died. Some people say that they would not want these things like CPR, shocking, and intubation, and then that goes along with a do not resuscitate, do not intubate. I also bring up life support in there because sometimes people don't realize that an intubation or the breathing tube in their lungs is actually considered to be life support. Others say that they would want these interventions done, so then that would be a full code. This is from our state DNR form. So it just kind of lays out what is provided to somebody who's a do not resuscitate, do not intubate, and what isn't. So again, for people that are considered to have died, we are not going to do things like chest compressions or putting in an advanced airway, administering cardiac resuscitation drugs, or putting somebody on a ventilator or shocking them. But if somebody looks uncomfortable in the mere moments before their death, we're always going to make sure that they have a clear airway, they're not choking, because that's not, people don't die. We don't allow people to die from choking. If there's bleeding, we manage it, pain, things like that. So people need to know not so much what we're not going to do, but what we will do. So the other thing people ask is, what does DNR mean for my other treatments? And I'll say that the decision to accept or decline CPR doesn't impact other treatment options. You can still get those treatments we talked about earlier. And just confirming that a DNR does not mean no treatment, and it does not mean no more hospitalizations. So some people say, no, I'm not going to be a do not resuscitate because I'm not going to give up. And I'm going to say that being a DNR doesn't mean that you're giving up, and that we need to weigh the risk and benefits of any medical intervention that might be done to us or your loved one. And we talk about consent in so many different things. I mean, the amount of consent for doing sometimes medications or, a surgery, things like that. We go through a consent process. So why is doing an extreme intervention like invasive CPR and life support any different? It's just not thought of in the same way. Basically, we're trying to consent somebody for something that we don't know when it's going to happen. So it's just a different thing for us to wrap our heads around and to educate families that this is the most invasive thing that can be done to them or their loved ones, and that they need to understand that and be accepting of the risk and benefits of what comes with CPR. And also I'll say that you're not giving up, you're just making a choice and placing limits on what interventions you want done to you or your loved one's body. So this is a chart that one of my palliative care colleagues at Frederick in the clinic, it's part of a larger packet of information. But I thought, some people like pictures. So if you look at this bottom lighter color down here, if you say that this is for people that have been in hospital cardiac arrest, and those that are over the age of 75, 85 of them will die. 15 of these 100 people will survive CPR. So that's the darker faces here. These people will survive. However, it's important for family members and loved ones to know that of those survivors that survive and leave the hospital, only about a quarter of them will go home independently or near independently. A quarter of them will go home, but that they'll require some type of additional assistance and they won't go home the same person. And at least half of them are going to have to live in some type of a long-term care, something like that setting where they get more supportive care. And also at least half of them are going to have problems with memories, attention, things like that. So I always say that CPR doesn't fix the things that we already have. It doesn't give us new lungs, a new heart, a new brain. We are going to have dementia if we survive CPR, and it is going to be worse. And that's something good for families to really understand for an appropriate consent if they want CPR. You can always revoke your code status at any time. I always tell families that. And sometimes families will bring up religion and say that their religion does not allow them to be a do not resuscitate, do not intubate. And it can be really difficult to respond to because a lot of us don't share the same religious backgrounds. And the way you respond to that is with emotion. There's a theme. So you want to say that it sounds like your religion or spirituality is important to you. Tell me more about that. You can also say, after you kind of explore that, you can talk about that choosing a do not resuscitate, do not intubate is not causing somebody's death. It's not preventing improvement. It's not preventing a miracle from happening. It's allowing a natural death once it's somebody's dying time. And you can always offer to contact a spiritual leader if that would be helpful for them. So somebody decides to transition to a do not resuscitate, do not intubate, your job isn't done there. We always recommend to get a community DNR paperwork and bracelet done so that this alerts the wishes, somebody's wishes, no matter what happens. So let's say something happens in public, then 911 and bystanders know what that person's wishes are. And I always recommend education to family, friends, or powers of attorney, what somebody's wishes are, so that it's not a shock if people find out somebody has changed to a do not resuscitate. If people can't decide now, that's okay. You would place them as a full code. You would confirm that there'll be more conversations coming with either them, their primary care doctors, their friends, families, things like that. And also we should, just a plug for that, we as medical professionals should be comfortable with providing recommendations. For example, a cardiologist does not pause when recommending a low-dose aspirin or different cardiac medications. A geriatrician or a neurologist in the right patient is comfortable prescribing and recommending maybe dementia medications for somebody to slow the progression of dementia. So recommending a code status either way should also be something that we're comfortable with as providers. A couple of additional acronyms that are helpful. I kind of talked about naming the emotion earlier. There is an acronym called NURSE. I really like the N part of NURSE, so name the emotion. Again, respond with emotion initially. If people want a medical explanation, they will always ask you again because they won't be satisfied with the emotional response. And just some additional bits. So, you want to talk about understanding. You want to talk about respecting somebody, and maybe you have that family member who's a fierce advocate for their loved one, or you see that they're dealing with a lot. So you want to kind of acknowledge that, provide support, and you're never wrong to say, tell me more. I usually try to end any of my new subacute rehab or long-term care admissions with what else is important for me to know about you or your loved one. That's usually where you'll get the best information. And always be ready to communicate with staff members any of these concerns that you come up with during this discussion. So then we have moderating a family meeting or breaking bad news. this is what I learned. It's called spikes. So it's a really easy thing that either you can look up or other people can look up if you're doing training for residents. So it's all about setting up the situation, starting with introductions, getting the perception from the family or the patient. So what have you heard about your mom's dementia? What have you heard about where she is with her swallow or her weight loss? And that'll give you an idea of kind of where they're at, because that'll lead into the invitation and information. So it's kind of your warning shot. So once you know where they are at, their perception of medical, of where their loved one is, then you can say, you know, is it okay if I share with you what I see or what I know? Is it okay to share this information with whoever is in the room? And say that we're going to talk about some hard things about your mom's dementia or their swallow or things like that. You want to share your knowledge. If they are accepting of that invitation, then you're allowed to talk honestly and frankly about where their loved one is at. And then you want to provide them some time, because it's probably going to be a lot of difficult things that they're hearing. And you want to say that, you know, I can't imagine how hard this is to hear. And you just want to make sure that you're giving them time and space to process, because if they're not ready to process more information, then anything else that you say to the family isn't going to be absorbed, and you're going to have the same conversation again. So if you're reading the room and it seems like nobody's ready to move on and talk about next steps, such as a strategy or summary, then that's a good time to say that we've talked about a lot of things today. Why don't we plan on a follow-up phone call or a follow-up meeting in X amount of time? Because if you keep talking and they're not ready to hear, you're going to have the same conversation again. This is from the Journal of American Medical Directors Association. It was a great article with interventions guiding advanced care planning discussions. It was a good review. It had a lot of great one-liners and ways to talk about advanced care planning and some of these difficult discussions. And then just some additional things that help. I still have this hospice eligibility card that you can download online. You just look up hospice eligibility criteria, and it's like a 2-page document PDF that you can print off. I always keep it with me. Palliative Care has some great like one-liner or great 1-page fast facts for some of these things, as well as also the geriatric fast facts. And both of those are through Freighter, but you can find them readily online. So I just want to say thank you to everybody. And, you know, I think I have maybe a couple minutes. So if there are any questions, feel free to ask them now and I'll try to answer. Otherwise, you can always email me.
Thank you so much, Dr. Bukowy. That was a great presentation, and really, you really shared a lot of clinical pearls on how to approach this sensitive subject, which is so hard for us to address. So if people want to put questions in the Q&A, or raise your hand. And while we're waiting, just in case people do have to run, I'm going to go over a few closing remarks, but please, in the meantime, put your questions into the Q&A for Dr. Bukowy as well. So let me go ahead and share this, and then we'll come right back to questions. You're seeing that okay?
Oh, yep. So I see what is the coverage for palliative care and how can one access it? Great question. It's not, because it's more of the philosophy of care, there's not really a insurance benefit for it. You can get certain home care and hospice agencies do provide a palliative care support system. And that's really wonderful, because maybe somebody is getting home care, and then they have a palliative consult or support, and then they move on to hospice. So that is something that you can always look into with something like a home care agency if your loved one is at home. It is an elusive thing and hard to find. You know, there's inpatient consults in the hospital. There is outpatient clinics that are available. But that's why, you know, a lot of this is, you know, the philosophy of it, and having some of these discussions, with family members, and having your support team if you work in a facility, or if you have other people that can help support you with the discussions. But it's a nuanced topic. I mean, we didn't start getting board certified for palliative care until about 2007. So it is an elusive thing. I would try to reach out to home care agencies if you have that available to see if that service is available.
Thank you. Other questions for Dr. Bukowy? All right, well, again, we are at time, but again, we really want to thank you so much, Dr. Bukowy. Thank you, Dr. Radue, Dr. Bouges, for your input. Again, thank you for stating that you'd be available for further questions. Again, we're so thankful to have such wonderful, talented, and compassionate physicians, clinicians in our state to be able to help us kind of work on improving our care for our patients with dementia and their families. So just a reminder, we will have the conference materials will be online starting November 18th with the recording as well. And then the slides also. And then also remember the conference evaluation link will be emailed to you tomorrow evening after all the events are done. And your feedback is really important. So again, we choose topics to really guide the presentations based on what input you have. So remember that CEU credits and CME credits will be done on the conference online evaluation. So make sure you follow those. And again, you have to claim those within 90 days. So that's important. And then we will be, tomorrow we'll be starting at 8:30 with our opening comments for our 20th annual ADRD update. So again, a nice celebration of 20 years of education and learning together with some really unique presentations about the concept of MCI, which was identified about 20 years ago. The RAP study, the Wisconsin Registry for Alzheimer's Prevention, which again started about 20 years ago. And then also hearing about unique updates on caregiving for unique family members, persons from underrepresented groups, and also working with exercise and trying to make some of those lifestyle modifications for our patients with mild cognitive impairment. So again, I really want to thank our presenters from today. I want to thank our planning committee, again, Jody Craner, Tammy Albrecht, Dr. Art Walasek, Dr. Maria Mora-Pinzon, and Sarah Klein. I want to thank our communications team, Claire Bittner, Sarah Klein, and Navina Jaspal, and also our evaluation team. So again, I failed to mention, so Uriel Penuega has done a great job with helping to revise our evaluations with Tammy LeCare. And again, thank Dr. Bouges and Dr. Radue and Dr. Bukowy today for wonderful presentations. And thank all of you for being here and taking time to really learn and try to improve our care for persons with dementia and their families. So we look forward to seeing you tomorrow at 8:30.